DECLARE-TIMI 58 was the largest of the trials looking at the SGLT2 inhibitor class in patients with diabetes, and it was pretty unique in that it wasn't just patients who had vascular disease, but there's a large primary prevention cohort with multiple risk factors. The primary results were presented last fall in 2019, and it showed that dapagliflozin versus placebo reduced the incidence of cardiovascular death and heart failure, as well as renal complications in this broad population, those that had vascular disease and those that had multiple risk factors. So it really extended the benefits of the class to a much broader population. So a subgroup from this trial was there were about 1,000 patients that had symptomatic lower extremity peripheral artery disease. And we looked at this population for two questions. First of all, this tends to be a very high-risk population, and we see in these trials that when there are benefits, even though the drug may work the same way in all patients, the higher risk patients get greater absolute benefits. And so we thought there's a high-risk population may get greater benefit. There had also been discussion when one of the agents, canagliflozin, was observed to have a hazard of amputation. We wanted to really understand limb events in this population. So we wanted to understand the efficacy in terms of the absolute risk reductions and the safety profile, particularly for limb ischemic events. So we found that patients who had peripheral artery disease versus those who did not were at significantly higher risk for cardiovascular death and heart failure and renal complications, and that the drug, in terms of the relative risk reductions, had the same benefit in those with and without PAD, but by nature of their higher risk, there were much greater absolute risk reductions in those with peripheral artery disease. So that was in terms of the efficacy of the drug. In terms of safety, we looked at a broad range of limb ischemic events: acute limb ischemia, critical limb ischemia, revascularizations, amputations. Overall in the trial, there's no imbalance with dapagliflozin versus placebo, which is very reassuring. And then we explored several high-risk subgroups, including those with peripheral artery disease, and we saw no consistent signal for harm. As we individualize therapy, there are a lot of tools in our armamentarium now. There's the SGLT2 inhibitors, the GLP-1 agonists, and so on. After the data from canagliflozin came out, I think a lot of people worried about using the SGLT2 inhibitor class in patients with peripheral artery disease. And there's a lot more work being done to sort of tease out the safety. I think these data are helpful in terms of personalizing therapy. If you have a PAD patient with heart failure who's going to get a real big benefit of the drug, I wouldn't deny them the drug because that one agent in the class was seen as having risk. On the other hand, I think that for patients that have critical limb ischemia, there may be other therapies that you're thinking about first in terms of salvaging the limbs. We didn't see a benefit of the drug in that regard. So I think these data are helpful in that regard. And I say in my practice, I see a lot of patients with PAD. I do use SGLT2 inhibitors, and I think these data reinforce that the benefits are significant. DECLARE-TIMI 58 is it's a large, rich data set. Not only are there all of the outcomes and different subgroups, and those will be explored in subsequent publications, there are also rich biosample databases, biomarkers, and other things to help us understand the biology of the drugs, understand if there are other ways of identifying patients who have greater benefit. So, I would imagine that over the next few months and years, we'll see a series of subgroups coming out with showing different types of benefit. And then more innovative analyses looking at biomarkers, genetics, other things like that.